You're listening to Clinical Conversations. I'm Joey Leo. This week, we talk about intermittent fasting. But before that, the week's top stories from Physicians First Watch and its editor, Amy Herman.
Thanks, Joe. First, a study in Finland finds that adults who start blood pressure or cholesterol medications may use them as substitutes for healthy lifestyle changes. In particular, those who started antihypertensives or statins were more likely to become obese than those who didn't start either treatment. They were also more likely to become inactive. Next, the CDC published its adult immunization schedule for 2020. Among the changes from last year, catch-up HPV vaccination is now recommended for all adults through age 26 who aren't fully vaccinated, and it may be appropriate for some through age 45. Elsewhere, the CDC this week issued new guidance on screening patients for novel coronavirus and assessing their risk for infection. The agency also started shipping its coronavirus assay to labs across the U.S. and in other countries, and cases continued to climb rapidly in China and slowly elsewhere. As of Thursday, China reported over 28,000 confirmed cases and over 560 deaths. And finally, in a comparison of several treatments for opioid use disorder, only buprenorphine and methadone were consistently associated with lower overdose risk compared with no treatment. Other treatments like inpatient detoxification, intensive outpatient treatment, and naltrexone did not show a significant effect. And that's our news for this week. Stick around for Joe's latest clinical conversation.
Dr. Ali Raja joins me again as co-host this week. He is the editor-in-chief of NEJM Journal Watch Emergency Medicine and executive vice chair of the Emergency Medicine Department at Massachusetts General Hospital. In late December, the New England Journal of Medicine published a review article on the effects of intermittent fasting on health, aging, and disease. Our guest, Dr. Mark Mattson, co-authored the article. Dr. Mattson is with the Department of Neuroscience at Johns Hopkins University School of Medicine in Baltimore. Welcome to Clinical Conversations, Dr. Mattson.
It's good to be with you.
During intermittent fasting, what generally are the metabolic changes that benefit the body?
Intermittent fasting can be defined as an eating pattern that includes periods of time with taking in no food or caloric beverages sufficient to deplete liver glycogen stores, which is glucose, and mobilize fats and produce ketones. So typically there are two sort of phases in rise of ketones after onset of not eating, and the first occurs beginning about 10 to 12 hours, and levels rise from undetectable to 0.2 to 0.3 millimolar, and then after 24 hours there's a second rise, and by 48 hours ketone levels go up in the millimolar range. But the evidence is accumulating that even these short periods of metabolic switching to fats and ketones, for example, 16 hours, is sufficient to have health benefits. And
you call it in the article a metabolic switch, and that the use of ketone bodies as opposed to glucose under normal feeding 3 times a day. But after intermittent fasting, the body begins to rely on ketone bodies for its energy source.
The metabolic switching, there's much more that goes on besides just a change in the energy metabolism and ketone elevation. Mm-hmm. Ketones support the function of cells during fasting, particularly excitable cells like muscle cells and nerve cells, which we study mainly. Uh-huh. But ketones also have signaling functions, and there are other ketone-independent effects of intermittent fasting that are emerging as being important.
So, Dr. Mattson, as a physician, when I discuss this with my patients, one of the biggest issues that I run into is that Western culture really treasures the idea of 3 meals a day. It's what we've done in our culture for forever. So how do I, when I'm talking to my patients, get my patients to actually be receptive to the idea of cutting back? What works when I talk to them?
First, from a historical perspective and evolutionary perspective, it's fairly recent that humans have had food available all the time and therefore have the luxury of eating 3 meals a day plus snacks. And so it's been about 10,000 years, actually much less than that for many populations in the world. We evolved in environments where food was scarce and an intermittent fasting type eating pattern was normal. It's obvious with predators where they may only kill prey every week or so, but it's also true with hunter-gatherers. They don't wake up in the morning and have breakfast waiting for them. They have to expend effort, and their brains and bodies have to function well in a fasted state for them to be successful. So one thing to point out to the patients is that actually eating 3 meals a day plus snacks is abnormal based on human history. And then the second is that it takes 2 weeks up to a month for people to adapt to the new eating pattern. For example, if the idea is they're going to start skipping breakfast, initially they're going to be very hungry and irritable and can't concentrate because they're hungry in the morning. But by about 2 weeks and by a month, and pretty much all the people that we've studied and the studies I've been involved with humans, they adapt and they're no longer hungry during the time period that they would have previously been eating. And that's analogous to exercise. If you've been sedentary, it takes you a while to adapt to exercise so that you not only don't feel bad when you're exercising, but actually feel good. And then another thing is, and this particularly applies to overweight or people with obesity, but also other people, they may want to do it with friends, and they can converse with their friends while they're during this transition period. And the physicians can also be cheerleaders and during this first 2 to 4 weeks. And if the patients can get through that, it's very likely that they will have adapted to the new eating pattern.
That's a great point, especially the last one you made. When I counsel patients on stopping smoking or making other dietary changes or starting exercise, doing it with a spouse or a partner or friends always makes things a little bit easier. And in fact, when it comes to stopping smoking, doing it without your spouse or partner who might live with you stopping as well makes it almost impossible to actually stop. So I love your idea of doing it as a team effort. You mentioned skipping breakfast, which is part of time-restricted fasting. In the article that we're talking about, you discuss daily time-restricted fasting, 5 to 2, alternate day. Can you run through the main types of fasting briefly?
Well, as far as human studies and what people are doing based on the press that's emerged over the last 4 or 5 years with intermittent fasting, are 2 approaches. One, the daily time-restricted eating, limiting food intake to 6 to 8 hour time window each day, and another called 5-2 intermittent fasting, which was based on studies by Michelle Harvey that we helped her with in England, and over 200 overweight women. We randomly assigned them to 2 days a week eating only about 600 calories. The other 5 days they were advised to eat normally, don't purposely overeat. Then the control group in those studies were the women ate 3 meals a day, spaced out, and each meal had 20% fewer calories than their estimated calorie intake prior to being in the study. It was designed that way because we calculated that, say, over months, this was 6-month studies, the calorie intake of both groups would be about the same. And indeed, both groups of women lost the same amount of weight, but the women on the 5-2 intermittent fasting lost more abdominal fat, and they had greater improvement in insulin sensitivity. So that was the first human study dissociating at least a couple beneficial effects of intermittent fasting from calorie restriction. And then as far as alternate day, our animal studies have, except for a few recent studies, all been in where we do every other day food deprivation. The animals don't have a choice. And all of those studies are the animals 24 hours no food, next 24 hours they have food the whole time, and keep that up. If you start that when they're young or middle-aged, they live much longer, and we found many health benefits, including a lot for the brain, which is mainly what we've studied with our intermittent fasting studies. And then it's turning out, and there's really no published evidence for this, but the feedback that people are getting who are performing human trials of intermittent fasting are finding that it's easier for most people to adapt and stick with long-term daily time-restricted eating versus 5-2 intermittent fasting.
That's actually one of the things that I was wondering, and that helps a lot because personally that I do, we'll actually ask some questions about this later, but I do time-restricted fasting and find it very doable. I would find 5-2 a little bit harder. So good to know that personal experience is generalizable.
Dr. Mattson, do you personally observe a fasting regimen?
Yes, I don't eat breakfast. I haven't eaten breakfast for over 30 years, but initially it was just by accident. I was a graduate student at University of Iowa, and we lived about 7 miles from the campus, and I rode bike in and back every day. And I had gastric reflux at that time. And I found if I ate breakfast right before riding my bike in, it'd exacerbate the gastric reflux. So I just quit eating breakfast for that reason. Typically, what I eat pretty much all my food within a 6-hour time window most days. I'm recovering from a mountain bike accident. I had to have 2 surgeries, so I'm not getting much exercise like I want to right now. But normally I would exercise at the end of the midday before I ate anything. Because I found if I eat, even within 3 to 4 hours of exercising, I just found I was better off not eating anything before I do that.
So it's become a part of your routine, and you don't notice that I guess you would notice that you're hungry, but you don't approach it with dread. It's just part of your.
No, I don't notice I'm hungry. I don't know if Ali has found this true in his case, but again, within a month or so, most people are no longer hungry during the time period they normally had been eating.
And that at N of 1 with an N of 2, that I also don't I don't feel any hunger when I do this anymore.
Okay.
Yeah, that's the feedback that I get from a lot of people who have switched their eating pattern.
I'll ask an obvious question with maybe an obvious answer, but do you think that the current animal and preclinical studies are robust enough to advocate intermittent fasting for routine clinical use?
For patients with obesity or overweight who haven't managed to reduce their calorie intake or get exercising enough to get their weight down, it can be one approach that they may be able to adopt that will help them. And I'm confident it's perfectly safe to switch the eating pattern. And so I would look at it as being complementary to exercise and reducing calorie intake in overweight people. In normal weight people, there have been some studies in humans. It's mainly they've looked at resistance training and found that people can build and maintain muscle mass just as well on intermittent fasting those were daily time-restricted eating studies, and they can enhance their loss of fat. In fact, my understanding is that a lot of bodybuilders will not eat breakfast and then do their weightlifting at lunchtime, right before lunch, and then eat after that. They take in way too much protein. It's probably not healthy, but the point there is that with intermittent fasting, you can build muscle mass and lose body fat if you have a need to or want to lose body fat.
That's great. And as a final question, ever since your review article came out last month, I've been using it frequently with my colleagues and sharing it. But I tried sharing it with a couple of non-medical friends, and they found it dense and difficult to read without a medical background.
Oh.
And so which you would expect, it was not targeted towards them. So are there any patient-focused literature articles that you would recommend that I can hand out to my patients and my friends who are not medical to help teach them about this?
Well, there are multiple books, and for the most part, they're all fine. What led to the popularization of intermittent fasting is the studies we did with Michelle Harvey in England. BBC producer picked up on those studies after we published them in 2011, and his name's Michael Mosley. He did a BBC documentary in which I was featured with a couple other scientists, and he played around himself with a couple different approaches to intermittent fasting, although he didn't try daily time-restricted eating, so he adopted 5-2 intermittent fasting based on our study, and he wrote a book called The Fast Diet. And then I think most of the books are fine. This isn't rocket science in terms of practical aspect, restricting eating during certain times, either daily or a couple days a week. So I think it should be easy to understand for most people. It hasn't been my experience that, when you start to get into what exactly is happening with switching energy metabolism, and there's many other, and there's many signaling pathways that are activated or inhibited, mTOR, autophagy, then of course they get lost. But from a practical standpoint, it seems even easier to understand than a South Beach diet or these other diets where you have to learn the composition of the foods and stuff. This, you don't. It's not that. It's just changing how often.
Right. Well, I want to thank you very much, Dr. Mattson, for talking with us today.
You're welcome, and have a good day. Oh, I should also mention as an aside, when we initially wrote the New England Journal article, we had it twice as long as it ended up, and they made us cut out a lot of the basic research so that, which, of course, the MDs wouldn't understand.
That was our 251st episode. The whole collection is searchable and available free at podcasts.jwatch.org. Clinical Conversations is a production of the NEJM Group, and we come to you from NEJM Journal Watch. The executive producer is Kristen Kelly. I'm Joe Elia.
And I'm Ali Raja. Thanks for listening.